Good morning, everyone. Happy Friday. Welcome to another edition of PT on Ice. My name is Jason London. I am a faculty member with the Institute for Clinical Excellence and teach rehabilitation of the injured runner as well as rehabilitation of the injured cyclist. And today what I wanted to talk about was patellofemoral pain, going a little bit deeper into some topics with that. As some of you are aware, and those that aren't, patellofemoral pain syndrome is the number one running-related injury, as well as the number one reason for knee pain in the injured cyclist. So a very good topic to cover here this morning. And there's a patellofemoral pain group that meets every 2 years, and then they have recently just published a consensus statement on using a pathomechanical model to explain some of patellofemoral pain and what may be going on in our patients. So I'm going to review this evidence-based framework for a pathomechanical model of patellofemoral pain, the 2017 Patellofemoral Pain Consensus Statement from the 4th International Patellofemoral Pain Research Retreat, Manchester, UK, Part 3. The authors are Chris Powers, Eric Whitrove, Irene Davis, and Kay Crossley. And again, this consensus statement is coming out of a meeting that was in 2015. They have these meetings every 2 years, and so the last meeting was actually this past July. And this consensus statement is strictly dealing with looking at a pathomechanical model for patellofemoral pain. They do acknowledge that in persistent patellofemoral pain, there can be altered nociceptive processing, altered somatosensory processing. Basically, they do acknowledge kind of the pain science model, but also indicating that there really is not a lot of quality studies published yet on pain science with patellofemoral pain. Good morning, Brandon. And so hopefully we'll see a consensus statement or some more research on more pain model, pain science for patellofemoral pain in the near future. But this is going to cover, again, a pathomechanical model for patellofemoral pain. And the main statement is that, I'll read it here, persons with patellofemoral pain exhibit elevated patellofemoral joint, cartilage, and bone stress during functional tasks. However, this finding is not consistent across studies. Currently, no prospective studies have linked elevated mechanical stress to the development of patellofemoral pain. Of course, this is usually what you're going to find in consensus statements, just because of the difficulty with doing research in sports medicine and orthopedics, and finding consistencies across those studies just based on differences in study design. However, there is good evidence to show that there is abnormal loading of tissues around the patellofemoral joint, particularly the retinaculum, the subchondral bone, as well as the ligaments, so myopatellofemoral ligament and the infrapatellar fat pad. And for reasons why this could be happening is statement 1.1, elevated patellofemoral joint stress can result from diminished contact area in persons with patellofemoral pain, but this is variable and likely dependent on the knee flexion angle. And of course, this makes sense. It would be dependent on the knee flexion angle. So again, when the knee is in a more extended position, the patella is not seated firmly in the trochlear groove, and therefore you can have less contact area of the patellofemoral joint. Basically, in cases with patellofemoral pain, increased loading at focal areas, usually more on the lateral facet of the patella, increasing joint stress. And this is consistent in populations with patellofemoral pain, where they typically see abnormal joint loading at those lower angles of knee flexion. And so this is, from a treatment perspective, where taping could be a a modality to try early on for pain management. Using mechanical taping or kinesio taping, really just trying to increase patellar contact area in those individuals and decrease pain. There's mixed evidence out there for that, but there is fairly consistent evidence showing for short-term pain relief. And I'll say from my clinical perspective, I have found patellar taping to be a really good modality to use early on in the treatment of individuals to try to decrease symptoms and allow them to do more functional tasks with decreased pain while we're addressing other issues. So again, you wouldn't want to use taping just as a standalone method. The next statement is patellar malalignment or maltracking in persons with patellofemoral pain can contribute to diminished contact area, but only in a subset of persons with patellofemoral pain. So again, not taking a cookie cutter approach to our patients, but looking at the patient in front of us and noting that there could be patellar malalignment or maltracking, but not necessarily. And if that is contributing, figuring out what is the cause of that patellar malalignment or maltracking in terms of movement impairment syndrome. Is it faulty mechanics, or maybe are there some static alignment issues, which I think is the next one. We'll jump ahead here to looking at static alignment issues on the influence of patellofemoral kinematics. So patellar alignment and patellofemoral joint kinematics are influenced by the bony geometry of the distal femur, patellar height, but not the static quadriceps angle or Q angle, which historically has been referenced a lot without very much evidence of looking at a static Q angle, or basically the kind of the resting angle of the knee in relationship to the ankle and the hip. But there really isn't any evidence for that. There is good evidence, though, for differences in patellar alignment by looking at if they have patella alta, so their patella is riding too high. Basically, their patellar tendon length is abnormally long, so that patella stays outside of the trochlear groove for a longer amount of time during knee flexion and is not as stable, so we can again get that asymmetrical distribution or kind of hot spot underneath the lateral facet of the patella. Patella alta is diagnosed using radiographic studies and again taking a ratio of the length of the patella versus the length of the patellar tendon. And then also we can have a shallow sulcus, particularly on the lateral aspect of the femur, again, as you would expect, leading to abnormal patellar mechanics. Another statement that they have here is impaired quadriceps function is a common finding in persons with patellofemoral pain, but its role in patellar malalignment or maltracking is unclear. There really has not been any studies to support lack of timing with the VMO versus the VL for a cause of patellar maltracking, but quadriceps weakness is a consistent finding in groups with patellofemoral pain. So making sure that we're not just focusing in on hip strength, but really looking at knee strength as well with our patients. Internal rotation of the femur can contribute to patellar malalignment and maltracking. I think there's very good evidence for this. Chris Powers has a great body of evidence to support this and really well done studies for that. So again, looking from a movement analysis perspective, in this case with specifically for runners and cyclists, making sure you're looking at them while they're running, doing some gait analysis, and then for cyclists, getting them on the bike and taking a look at how they're moving and how their fit is for the bike. Statement 1.1A3, there is evidence that persons with patellofemoral pain exhibit impairments related to soft tissue restraints and that these impairments may contribute to patellar malalignment and or maltracking. Specifically, the IT band is stated here, and I will say I have found that not across all patients, but to be a pretty common finding is IT band tightness, and then thinking of how that again could contribute to patellar maltracking with that increased lateral tightness from soft tissue restraints on the patella, again making it more lateral as it goes through the flexion extension cycle. So from a clinical perspective, again, looking not just right at the knee and looking at the individual and looking at their IT band length or tightness, and then giving them some stretches, some myofascial release and foam rolling to do. Let's see, moving right along, patellofemoral joint reaction forces in persons with patellofemoral pain differ from those in pain-free individuals. Again, just supporting their first overarching statement, and realizing that those joint reaction forces are higher, particularly at those lower angles of knee flexion. Again, when there's going to be more variability between individuals, when that patella doesn't have as much bony congruency, when it's not in the trochlear groove. Persons with patellofemoral pain exhibit differences in tibiofemoral kinematics in all three planes of motion compared to pain-free individuals, but not consistently across all studies. So again, really looking at, what are the mechanics going on at the knee. For runners, typically see, and cyclists see a knee abduction, or basically a dynamic knee valgus occurring. And then we would want to, of course, address this through movement retraining. And then they go on to say how, as you can imagine, that altered tibiofemoral joint kinematics also can influence the altered tibiofemoral kinematics as a result of altered tibiofemoral mechanics can result how that contact pressure is on the patella, again with looking at kind of more of an asymmetrical distribution of force and decreased contact area overall, but really increased contact area on one aspect of the patella. Persons with patellofemoral pain exhibit altered hip kinematics. However, findings are not consistent among studies. That common theme of not being consistent among studies, and really looking again at what are those joint moments occurring from the hip due to abnormal mechanics occurring at the hip as well, with that increased femoral internal rotation and increased femoral adduction. And then there's really hasn't been evidence to show for altered hip structure, bony anatomy, that is causing this difference in hip kinematics and mechanics in those with patellofemoral pain. And then moving lower down the kinetic chain, excessive rotation of the tibia accompanies subtalar joint pronation and may be a contributor of patellofemoral dysfunction. And a subset of persons with patellofemoral pain may exhibit altered foot mechanics and plantar pressures. Measures of dynamic foot function are not consistent among those associated with patellofemoral pain. I think this goes on to really say, we do have that influence of what is happening at the foot and ankle and how that can influence the patellofemoral joint, and looking at the patient in front of you and looking at how they're moving, particularly at the foot and ankle, and how could that be influencing the patellofemoral joint. I think this is really important to look at, especially in cyclists, since they're in that more of a constrained system, and use of a orthotic, either off-the-shelf orthotic or a custom orthotic, can be warranted in these scenarios, particularly for the short-term pain relief. There's good evidence to support that. Not as great evidence for long-term. I tend to see and use orthosis, foot orthotics, more in cyclists than I do in runners, where in runners I'm looking more with retraining movement impairments that I'm finding. And then just going on again to kind of support how kinetics, there can be differences in kinetics along different joints compared to pain-free controls. And then again, how the influence of pathomechanics can be contributing to that. And then moving further up the chain from the hip, persons with patellofemoral pain exhibit differences in ground reaction forces compared to pain-free individuals. And persons with patellofemoral pain exhibit differences in trunk kinematics compared with pain-free individuals, but findings are not consistent. Again, I guess looking at ground reaction forces, particularly in running, you want to look at, do they have a higher rate of loading, really by just listening to them running and then taking cues from other aspects of their gait. Basically, do they have excessive vertical displacement while they're running? And then, of course, that would be something you want to address with some cueing and gait retraining. And then looking at trunk position, in this case I'll speak more about runners than in other activities, but it's really important to look at it. Do they have more of an upright trunk posture, or can they have a little bit more of a forward lean in the sagittal plane? And that has been shown to really decrease forces around the patellofemoral joint. Trying to do that as a movement retraining, but also then thinking, is there weakness in the trunk and hip musculature that could be contributing to their inability to maintain that forward lean, particularly in the hip extensors, the gluteus maximus, as well as the spinal extensors. And they go on in this consensus statement to talk about the influence of hip and trunk muscular performance on altered trunk kinematics. And then lastly, looking at tightness of different muscle groups around the knee, particularly the quadriceps and the hamstrings, and how that can influence mechanics, as well as how that is a consistent finding in a lot of groups with patellofemoral pain, is increased quadriceps and hamstring tightness. So making sure that you do address that as well. So in conclusion, I think this is a good paper to touch base on if you're treating anyone really with patellofemoral pain. I'll include a link at the end here. But from looking at strictly a pathomechanical model for patellofemoral pain syndrome and realizing that there are non-pathomechanical factors occurring too, but this is a good study that we do want to individualize treatment based on, in this case, a runner or cyclist in front of us. Initially, taping and use of orthotics could be warranted for short-term pain relief, but the most evidence really relies in exercise, treating patellofemoral pain with exercise directed at the hip and the knee, and then addressing movement impairment patterns, irrespective of strength weakness. So someone could potentially be strong and just have poor motor planning, and really diving in and addressing this. And for the runner, that really means analyzing their gait. For the cyclist, it means getting them on the bike. If you want to learn more about that, you can certainly listen to other episodes of PT on Ice, or come and would love to have you at one of the rehabilitation of the injured runner courses, or rehabilitation of the injured cyclist courses. Coming up this weekend, there is the fitness athlete course in Anaheim. In a couple weeks, Eric Chaconis is going to be out in Las Vegas for the extremity syndromes course. And then there's also a couple fitness athlete courses coming up too. Head over to ptonice.com if you're interested in learning more about our courses and when those are occurring. Otherwise, thanks for listening. I hope you have a great weekend and a great upcoming 4th of July week. Cheers.